Hello, my name is Mallory Williamson, and I am here today to present my capstone experience. The patient that I will be presenting on today was a 35-week-old neonate that was transferred to this larger facility in South Dakota. Baby was transferred related to a complicated labor, and this happened in a nearby smaller town. So a little backstory, mom had a healthy pregnancy. She had twins. So this patient of mine was a di-di twin, meaning that both babies had their own amniotic and chorionic sac. Mom had an uncomplicated pregnancy up until she was admitted for premature rupture of membranes and preterm labor. She underwent a C-section, which was uncomplicated and went smoothly. And after that, the baby was transferred. So at the time of the birth, the patient's APGARs were 5 at 1 minute, 7 at 5 minutes, and again 7 at 10 minutes. Baby did cry at delivery and did also require a period of PPVs related to bradycardia, and the baby was transitioned to CPAP plus 5 for respiratory distress. Baby was also given erythromycin and vitamin K and the Hep V vaccination. Upon admission into the hospital that I was at, where I was caring for this infant, the baby was put on 2 liters of high-flow nasal cannula at 21% FiO2. Capillary blood gas on admission showed respiratory acidosis. D10W and feeds were initiated. The infant was taking mother's breast milk, donor's breast milk, and also a formula called NeoSure 22. On day 3 of the stay, the patient had 2 bloody stools, and there was suspicion for neck. At that time, the D10W was discontinued. The patient was made NPO and TPN was started. I'm going to now talk about my nursing assessment. In general, the patient was active and alert. The head was normal cephalic, fontanelles were flat and soft. There was no eye drainage noted, and the baby's neck had full range of motion. The nose was pink, moist, the membranes are moist, and I did not note any breakdown in the nares related to the prongs. Cardiovascular, I did not note any murmur. The patient had a regular rate and rhythm, and pulses were appropriate. Lungs were clear to auscultation bilaterally. The baby was grunting intermittently, and mild retractions were noted, and the respiratory rate was a bit elevated. Musculoskeletal, the arms had normal morphology, legs had normal morphology, skin color was appropriate for race, normal range of motion, and also no hip clunks or clicks were noted. Upon assessing the spine, there was no evidence of a defect, and the infant's muscle tone was appropriate throughout. They had good muscle tone. Skin was pink, warm, and intact throughout. I did not notice any bruising, scrapes, or any discoloration anywhere on the infant's body. The patient was alert. Their pupils were equal and reacted to light. The baby responded to stimuli, and I did notice that the moral reflex was present. Overall, all my assessments were considered to be in normal range. I was not worried about anything that I found. So I picked 4 nursing diagnoses that I wanted to discuss. The first one is a risk for neck, as evidenced by 2 bloody stools. Second one, a risk of ineffective feeding secondary to prematurity. Third one is risk of increased bilirubin related to prematurity, as evidenced by increased bili labs and yellowing of the skin and sclera of the eyes. And my fourth one is readiness for enhanced comfort, as evidenced by crying and irritability during CPAP prong changes, cares, IV placements, and suctioning of the mouth and nose. For planning, for my first nursing diagnosis of risk of neck, a short-term plan is that the patient's neck will improve daily. Long-term, patient will not have any more bloody stools before discharge. And a public health initiative regarding neck would be education of neck and what it is and how your chances, the infant's chances of getting neck is increased with usage of formula. My second nursing diagnosis is risk of ineffective feeding. My short-term goal is the patient will tolerate feeds and increase daily volumes. Long-term, the baby will feed ad lib, which is on demand, with appropriate weight gain before discharging. Third, risk for increased bilirubin. Short-term, patient's bilirubin labs will trend down daily, and long-term, the patient's bilirubin lab will be within range prior to discharge. In my fourth nursing diagnosis, readiness for enhanced comfort, the short-term goal will be patient will be comforted with use of comfort measures as needed, and long-term, the patient will require fewer comfort measures before discharge. Moving on to implementation. For my first diagnosis, risk of neck as evidenced by 2 bloody stools. So the first order was that the infant was made NPO, so nothing by mouth. We then placed an OG down into the stomach, and also a Rapogal was ordered. And it was set on intermittent suction. We started a new IV. We administered ampicillin and gentamicin. We monitored for bloody stools, and there was daily labs drawn for a CBC, a CRP, bili, and a renal panel. There were also x-rays ordered every 6 hours of the chest and abdomen. And we were also monitoring vitals. For the second nursing diagnosis, risk of ineffective feeding. So this was prior to the infant developing neck. So the baby was put on low volume feeds of mom's breast milk, donor breast milk, and NeoSure 22 cal. We utilized the preemie nipple while bottling. Feeds were every 3 hours, and we gavaged whatever volume was left over that the baby did not take via bottle. We also increased feeds daily as tolerated. We monitored INOs, and baby's weights were taken daily as well. For my third, risk of increased bilirubin, there was a daily early morning blood draw for bili labs, and we made sure to check the bili labs for results prior to rounding so that we could discuss these findings with the care team as well as all the other labs that were drawn for my first diagnosis. And we also monitored the patient's skin coloring and sclera coloring of the eyes. And for my fourth nursing diagnosis, readiness for enhanced comfort, we implemented comfort measures. We used a bendy bumper, which provided boundaries for the baby. We used a bed warmer to ensure that the temperature of the baby was in range of 36.5 to 37.5. We swaddled the patient in a blanket or a sleep sack. Patients had their parents there at the bedside often, and they were also doing kangaroo care. Patient also used a pacifier, and whenever I had downtime and the patient was needing a little bit extra comfort, I would go hold the baby. Provide therapeutic touch to soothe. We also used a sound machine at times when we were not able to be at the bedside or the parents were not there to help soothe the baby as well. And we used Sweeties and breast milk on a pacifier during IV insertion to help soothe the baby. Evaluation. So after implementing all those above measures for the nursing diagnosis, upon evaluation, number 1, risk of neck as evidenced by 2 bloody stools. The patient labs and x-rays remained reassuring. During rounds, the provider did mention that the labs, since they were in range, that they were reassuring. The doctor did, one doctor would say that yes, the baby had neck, and another one would say no, so it was kind of, we weren't real sure if it was truly neck or not, but it was kind of, I heard different things from different providers, so we were treating it as it was neck. Patient labs and x-rays remained reassuring. The bowel rest allowed the gut to heal. 2, risk of ineffective feeding. Patient was tolerating feeds in increasing daily volumes until NPO status. After the baby was made NPO for 3 days and allowed the bowels and gut to rest, feeds were implemented starting at a low volume and then increased daily per toleration. And the baby did tolerate those feeds well. 3, risk of increased bilirubin. Bili levels went down a bit each day and they remained in range. And also the complexion was appropriate for race, and the yellowing of the skin in the eyes was diminishing. Number 4, readiness for enhanced comfort. Patient was consoled and calmed with use of comfort measures as needed. And I do want to talk about some of the above charts, the vital signs, heart rate, respers, temp, O2 is all there, height, weight, and head circumference. The labs, daily labs were drawn and everything was in range. We did a CBC daily, a CRP, a bili, renal panel. They were all within range, so I didn't go through and list everything. Medications that the baby was on was Poly-Vi, which is a multivitamin with iron, daily, and the baby was taking that up until they were made NPO. Then it was put on hold. The starter TPN was started, as well as the ampicillin and gentamicin, after the baby was diagnosed with a risk for neck or neck, dependent on which provider was there. Betamethasone was given upon delivery for development of lungs, as the baby was premature. And vitamin K and erythromycin were also administered on delivery. Some of the screenings that the infant had was a hearing screening order prior to discharge and a CCHD once off supplemental oxygen. And down in the right corner of my poster, I want to talk about health promotion and disease prevention. So blood cultures were obtained and identified negative for infection. Routine labs were drawn daily and assessed. The care team followed safety protocols as well as the parents, and patient advocacy was provided by nursing staff. Cultural considerations: the family was Catholic, and there were no other notes in the chart, and upon asking the parents if they had any other cultural considerations that they would like for me to implement, they said no other specifics. Coordination of care. So during rounds and all the care providers that I saw on the floor that were a part of taking care of this infant was a neonatologist, a nurse practitioner, a respiratory therapist, speech therapist, physical therapist, pharmacist, dietitian, nursing staff, and care techs. And that is the end of my presentation. Thank you.